I'm going to talk about transfusion strategies in ICU, and I thought we will break the tutorial into different sections as to what we understand about transfusion, why it's important, and thereafter we'll flow with the thought. As we all know, hemoglobin, which is a component of the red blood cells, which is responsible for carrying oxygen throughout the blood. This is a basic physiology that we all know. And anemia in critically ill patients is a very common problem. And because of its associated morbidity and mortality, it becomes of clinical importance, especially in critically ill patients. It's evident in the early part of critical illness, and the hemoglobin keeps falling throughout the stay in the ICU. By the third day in the intensive care unit, approximately 95% of your patients would have developed anemia. 50% of them would, on an average, receive 5 units of blood cells during the stay in the ICU. It's a commonly acquired issue while dealing with patients in the ICU because it's acquired partly from hemodilution, from blood loss, reduced red cell production, and enhanced red cell destruction. To top it off, compounded by the critical illness characterized by the decreased erythropoietin production, a blunted response, cellular response to erythropoietin, disordered iron metabolism, and nutritional deficiencies. Anemia is traditionally treated, as you all know, with the infusion of RBCs in order to increase the oxygen carrying capacity and the tissue delivery of oxygen. The rationale behind this has always been to maintain a certain level of hemoglobin in the blood. In relatively healthy individuals, physiology plays an important role in maintaining anemia to the vital organs even at very low hemoglobin levels, and we'll discuss this later as the slides progress. The amount of oxygen delivered to the whole body exceeds the normal requirement by 4-fold. And if an isolated figure of a fall in hemoglobin were to occur below 10, the oxygen supply would still remain twice the resting oxygen consumption. Humans have a tremendous ability to adapt to anemia. And they do that by increasing the cardiac output in a patient who's not losing blood, by increasing its microcirculatory density, and by increasing the red cell synthesis of 2,3-DPG, with the resultant shift of the oxy-dissociation curve, which aids in the oxygen disloading and by increasing its oxygen extraction. However, the extensive experience, which is always there with every clinician, there are studies that help us to understand the decline in blood where patients have not asked for transfusions because of their religious reasons. We've seen them in patients with chronic renal disease, myelodysplastic syndromes, severe autoimmune hemolytic anemias, and we all know they tolerate extreme anemia quite well. However, in critically ill patients, because of the increase in the metabolic demands, which overwhelms the compensatory mechanisms, this leads to an increased state of morbidity and mortality of anemia in critically ill patients. Blood transfusion over the years and centuries has been considered to be of clinical benefit and a very low risk procedure. Let me take you back into history where it all started. In 3000 BC, leeching was known to the Egyptians. In 1500 BC, it was even mentioned in Sanskrit, as noted by Alexander the Great. In 1301 to 201 AD, Galen, which was a Roman physician to the Emperor Marcus, popularized the concept of blood circulation. However, it was only in the early 17th century, in 1682, William Harvey was the first person to describe the functions of the heart and how the blood flowed. In 1684, Antony gave the first description of the red blood cell and made a study about the association between the arteries and the veins. However, in 1880, James Blundell was the first man to give a successful transfusion of human blood to a patient who had hemorrhaged badly during childbirth. The usual concept till this time was for any shortage of blood, transfuse it with blood. However, it was only in 1900 that Karl Landsteiner documented the first 3 human blood groups A, B, and O. Therefore, it's becoming important for us to understand what are the various blood components and why it is critical to make the decision to give the right transfusion. First, we'll run through the definitions. Any therapeutic product prepared from human blood is called a blood product. The whole blood is unseparated blood collected in an improved container containing anticoagulant and a preservative. A blood component could be either a red cell concentrate, a plasma, or a platelet concentrate. Cryoprecipitates are prepared from fresh frozen plasma which are rich in factor VIII and fibrinogen. Plasma derivatives are human plasma proteins prepared in pharmaceutical manufacturing conditions which include albumin, coagulation factor concentrates, and immunoglobulins. So the question arises, what do you need to transfuse? There are a few issues regarding whole blood if you need to transfuse. One is an issue called the autologous donation, where there is a collection of a normal testing and processing of patient's own blood for him or herself. And this can be performed specifically in an elective surgery, and it contains everything, the RBCs, the platelets, and the proteins. If you ask a friend or a family member to donate a blood group, a blood type for you, it has to be compatible. And in case of a first-line blood relative, it needs to be irradiated to avoid risk, including transfusion-associated graft versus host disease. I'll just run through the types of RBCs that are available. The packed red cells, which contain 200 ml of RBCs resuspended in a preservative, has an hematocrit ranging between 55 to 60 and a 200 milligram of iron, with a life of about 20 to 40 days. Each unit that you order from the blood bank is about 300 ml of blood, and it has to be transfused over 3 hours. 1 unit is expected to increase the hemoglobin by 1 gram percent and raise the hematocrit by 3 gram percent in a healthy individual who is not losing blood. Usually indicated to increase the oxygen carrying capacity in patients with anemia, and can also be used to increase blood volume only in acute blood loss. Type O is the universal donor, and the transfusions to keep hemoglobin between 7 to 9 gram percent in an ICU settings, of which we will discuss later, is what the comments are. The gamma irradiated RBCs, where the radiation is applied to the bag, is useful in patients who have stem cell transplant and in severely immunocompromised patients. The CMV negative blood is usually used for patients who are CME negative and are at a high risk of complications if infected with CMV, especially in transplant patients and pregnant ladies. A leukocyte reduction filter is quite an effective method in reducing the risk of CME infection. Wash the donor red cells if they're washed with normal saline so that you remove as much of serum as possible. This kind of a washed RBCs are usually required in patients who have IgA deficiency and in paroxysmal nocturnal hemoglobinuria in order to reduce the complement load. The next section is the platelets. These are the blood cells that are held for clotting of blood. Their donation of the platelet concentrates are through a cell separator, a pheresis technique, where only the platelets are taken out and the rest of the blood is sent back to the body. This procedure enables patients to donate blood every month and has a lifespan of about 5 to 6 days. Usually indicated in thrombocytopenia with bleeding and not when there is no bleeding, and do not transfuse in ITP. However, the prophylactic levels of transfusing platelets depends from one institution to the other. The normal recommendation is that any value less than 10, they should receive a transfusion. A blood that is processed through an apheresis machine, as we discussed earlier, and filters the plasma and returns the rest of the red cells and other components back to the donor system is sort of fresh frozen plasma when it's frozen and has a lifespan of almost a year. Any condition that you'd like to use is a bleeding in a setting of factor deficiency or a coagulopathy, warfarin reversal, or a DIC. The doses are usually 5 to 15 ml per kg, but generally the tradition is to give a few transfusions, recheck, then order for more. Proteins, the plasma proteins that are present in the plasma are further separated to prepare protein concentrates using a process called fractionation. Cryoprecipitate, indicated in fibrinogen deficiency, which is rich in fibrinogen as well as von Willebrand factor, factor 7, and fibronectin. Humate P another component used for the treatment of von Willebrand disease, types 2B, 2N, and 3. Factor 7 and 9 concentrates in hemophilia A and B respectively. Recombinant factor 7A in bleeding complications in acquired hemophilia, and factor 7 deficiency. So once we know what we are to order from the blood bank, we need to know when we need to transfuse. Transfusion practices differ widely among different ICUs, and it depends on a lot of individual preferences that doctors have. What is the hospital policy, and where and how the bloods are available. Despite all this variation, still we do not have an optimal management plan of anemia in the ICU well defined. Older position statements recommended that patients be transfused blood whenever the hemoglobin decreased below 10 or the hematocrit fell below 30%, the 10-30 rule. However, these recommendations were not based on randomized controlled trials, and they were rather based on tradition. This 10-30 rule was first proposed in 1940 and became very popular in the 80s. However, it was never supported with good evidence. In order to sort this out, a study was attempted to clarify this debate in the general medicine and surgical critical care community by doing a multicentric randomized controlled clinical trial on transfusion requirements in critical care. This was a study that conducted a randomized trial on 838 patients who were to receive transfusions for hemoglobin levels less than 10 or 7. The overall 30-day mortality was similar, but however, the in-hospital mortality in patients who were transfused for hemoglobin less than 7 was better. The results suggested that in a hemodynamically stable patient without the evidence of a blood loss, limiting blood transfusions may reduce morbidity and mortality, and the hemoglobin levels ranging between 7 and 9 could be well tolerated. However, in patients with cardiovascular disease who had a preoperative anemia, these patients were associated with a significant risk in perioperative mortality. These data also suggested that humans had the adaptation to adapt to a very low hemoglobin level. Only the limiting factor were patients who had a cardiovascular disease. Therefore, they suggested that a restrictive pattern of transfusion was tolerated and a potentially superior to the one in which you would do a liberal transfusion strategy. However, the only drawback of the study that one must need to understand is that there was no control group who were receiving routine care like this group, and that it had fixed just two values, 10 and 7, to titrate and study this. However, in general, RBC transfusions are only indicated in non-bleeding, hemodynamically stable ICU patients, trauma, and surgical patients with a hemoglobin concentration below 7. However, the need to transfuse RBCs should be individualized based on the patient's clinical circumstances rather than just arbitrarily looking at the hemoglobin value. So the decision to transfuse is patient and situation specific based on the systemic organ dysfunction, the anticipated blood loss, and the overall patient mortality. So the aim is actually that if you transfuse blood, it should be benefiting the patient. However, there are some studies that have come up over the recent decades that have suggested adverse effects in patients who have received blood transfusions. So what are the risks that we need to know? The risks that could be involved with blood transfusion could be organ failure, nosocomial infections, increased length of stay, increased morbidity and mortality. As red blood cells break down, they release cytokines which are pro-inflammatory and may be immunosuppressive. Therefore, a systematic review of literature done by Paul and Harvard studied the efficacy of red blood cells in critically ill patients. A systematic review involved a data source from Medline, Embase, Cochrane Register of Controlled Trials, citation review of relevant primary and review articles. The analysis suggests that in adult intensive care, trauma, and surgical patients, The transfusions of RBCs were associated with increased mortality and morbidity, and therefore the current transfusion practices must be re-evaluated. In 42 out of the 45 studies that were analyzed, the risk to transfused was high, the risk was neutral in 2, and the benefits of outweighing the risk in a subgroup of single study who had a patient who had an acute myocardial infarction and his hematocrit was less than 30. You could see the odds ratio in a transfusion with the risk as well as the pooled ratio, which was all in terms of causing harm in such a transfusion. Or the risk associated with transfusion and developing an infectious complication was also a negative study, and the odds ratio for a transfusion associated with a an adult respiratory distress syndrome was also a negative study. The study suggests that across a broad spectrum of high-risk hospitalized patients, RBC transfusions seem to be associated with increased mortality and morbidity. However, this is very remarkable because in our clinical practice, considering that we transfuse so many patients with RBCs, and it's done traditionally worldwide, the results of this study therefore must be interpreted with caution due to the nature of the study that relied on the association of differences in one characteristic, that was giving transfusion, and just maintaining what the outcome was. The other issue that was involved with the transfusion was the return of the oxygen. When it reached the ischemic area, it heralded the beginning of a reperfusion injury. And the molecular and the cellular basis for this was the endothelium, the leukocytes, the mitochondrial oxidative metabolism, enzymatic mediators of reperfusion injury, and apoptosis. However, understanding and finding an answer for these metabolic pathways is a current area of investigation so far. Therefore, it is very unlikely that we'll be able to, in the near future, just to say a single treatment that will help us to block these reactions and get us a process that is relatively safe. So the next issue that we do come to is, what are then the transfusion reactions? We know what we need to transfuse, we know when to transfuse, and once we transfuse, what we are to look forward to. The acute hemolytic reactions, the more serious and the immediate life-threatening, antibodies, the IgM in the recipient serum react to major antigens. They manifest as fever, dyspnea, tachycardia, back pain, hypertension, chills, chest pain, which occur within minutes of transfusion. And the treatment is to stop the transfusion immediately. The delayed hemolytic reactions, which react to minor antigens, manifests usually are asymptomatic, but sudden decrease in hemoglobin when a lab evidence you have documented in terms of hemolysis, positive direct Coombs test, and an increased indirect bilirubin concentration. The non-hemolytic febrile reactions occur in about 1% of transfusions and occur due to the antibodies of the recipient serum reacting to the WBC in the donor product. Sorry. It manifests acutely as an increase in body temperature, which settles down with an antipyretic therapy. Allergic reactions occur because of the transfused allergens and react either treated with antihistamine preparations. Transfusion-related acute lung injury, which presents as a rapid onset dyspnea, hypoxia, bilateral infiltrates resembling an ARDS kind of a situation where you have an absence of volume overload and heart failure, which is usually not a dose dependent and the treatment is supportive, is considered occurring as an end result of diffuse neutrophil activation and capillary leak from an immune and a non-immune process in the lung. There are some bacterial infections that you can transmit through blood transfusions, commonly being the cold-growing organism, Yersinia and Trochilita, and the gram-negative organisms. The long-term complications or the risks that occur include the hepatitis A, B, C, HIV, HTLV, and the parvo B19. I'll just finish my talk with a few slides on what to look into the future, what's coming and what's going to help us in transfusion, because the need for getting good blood, due to the chronic shortages, the usual ooze for booze, where people pay, they are drug addicts, they get money, they pay, they get transfuse blood for transfusions every 10 days, and of course the shelf life included for such storage issues with the red blood cells. Some of the replacement products that are coming up are the hemoglobin-based oxygen carrying solutions and the perfluorocarbons. Others include antigen camouflage, recombinant plasma proteins, transgenic therapeutic proteins, and platelet substitutes. Animal studies have demonstrated that polyheme improves recovery from post-shock oxygen debt and reduces acute lung injury. Animal studies using swine have established bovine polymerized hemoglobin, also known as HbOc201, is superior to dextran in terms of resuscitation and survival. Resuscitation with trans-sodium crocetinate, a vitamin A analog, has been used in animal models to improve oxygen delivery after hemorrhage. However, there are no clinical trials yet to support an infusion with TSE seems to be a promising issue in the near future. Thank you for your kind attendance.